Another video that has been in the works for some time. Let's talk about vaginal birth after cesarean delivery, or in short, VBAC. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at vaginal birth after cesarean delivery, or in short, VBAC. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon so you should be receiving notifications of such amazing content every time I post. Grab a piece of paper and your pen and let's go. So remember that any woman that has had a previous cesarean section actually is at risk of uterine rupture, they're at risk of hemorrhage, perinatal morbidity, as well as mortality. And this can occur late during the pregnancy, and it can also occur during labor. As such, the maternal mortality actually is a risk of about 5%, and the perinatal mortality is about 75%. Because of these adverse effects, as well as anticipated litigation issues, most women actually, or most decisions are actually to routinely undergo an elective repeat cesarean delivery. Because remember, in our day and era, cesarean sections are actually a very, very safe method of delivering. But for those that have had one previous Caesar before, one previous cesarean section, and they actually fit certain criteria, you may actually attempt to perform vaginal birth after cesarean delivery. And this is done successfully in some patients, and it should be attempted in our setting. Remember that every case should be individualized, and the decision to undergo this VBAC must be made both by the mother and the obstetrician. So the woman must be taught on the benefits and the risks of the VBAC, and you must pitch both sides, both the risks and the benefits of VBAC, and then the mother should make an informed decision. This counseling must start during the antenatal period as well as during the labor period. And once the woman actually makes a decision, this must be documented in the file clearly. And if a repeat cesarean section is actually chosen, then you must discuss and document the plan in the file. And remember, you must schedule a date for the surgery, an elective surgery for this woman. So you must always have a delivery plan for these women. So remember that when you're doing a cesarean section, generally you may make like two main types of incisions. They may be located in the upper segment of the uterus, or they may be found in the lower segment of the uterus. They may be horizontal, they may be vertical. So remember that these incisions that are made during the cesarean section are made on the upper segment. They can also be made on the lower segment. It's not enough to just look at the scar on the abdomen and then guess that this is an upper segment or lower segment cesarean section, because just looking at the scar on the abdomen, you can't really tell what type of incision is made on the uterus. The incision that matters the most is the one that is made on the uterus. So we're going to compare two main types of incisions. We have the lower segment incision, and we have the classical or hysterotomy incisions, the one that's made on the fundus of the uterus. Remember that the lower segment is not going to be cutting through any muscles, it's just going to be cutting through this elastic tissue, because the lower segment doesn't really have muscles, while the classical segment is going to be cutting through the muscles. Specifically those ones that have a vertical incision in the upper segment of the uterus, those ones are cutting through muscles, and these are going to be posing a big risk of uterine rupture. So remember that when these scars or these incisions are healing, when it comes to the lower segment scars, these are going to be having very thin margins, and this will facilitate this perfect apposition of the muscle such that you don't leave any pockets behind. It heals very well. So the scars that you actually get from a lower segment scar are actually quite sound and are at less risk of rupturing. While on the other end of the spectrum, those that are from a classical hysterotomy scar, these ones are going to be very difficult to oppose because of the thick muscle layer, and you may sometimes have these pockets of blood which subsequently can be replaced by fibrous tissue forming. And also there may be a gutter that forms on the inner surface that is likely to be the decidua more often than not excluded during the suturing process. Then remember that the state of the uterus during healing, when we look at the lower segment scars, these ones are going to be the part of the uterus that remains inert is the one that's going to take healing is going to take place normally, because this part doesn't have any muscle tissue. It's just pretty much elastic tissue, no muscle. So even when it's healing, it's not going to be affected by the involution of the uterus. While it's on the other end of the spectrum with the classical or hysterotomy scars, remember that as the uterus is contracting and retracting, this is going to be affecting the sutures. It's going to loosen up the sutures, and then this is going to lead to imperfect healing. Then also there is a stretching effect. Remember that the scar can be stretched during the future pregnancies and normal labor along the line of the scar in the lower segment scars. Then it can be stretched at right angles to the scars that are found in the classical type of incisions. And placentation in the future pregnancies, generally the chance of weakening the scar by the placenta attachment is unlikely, whilst in the classical incisions, the placenta is more likely to implant over the scar, and then it can weaken it by this trophoblastic penetration that we see, or herniation of the amniotic sac through the gutter, as we have seen in this picture here, where you have this amniotic sac that can actually penetrate through the scar, and this can actually weaken this point, and this could be a possible point of rupture. Then remember that the net effect is that the lower segment scars are going to be sound, while those that are classical are going to be weak. So the risk of rupture is quite low with the lower segment scars, about 0.2 to 1.5%, whilst it's much higher with the classical scars, about 4 to 9%. So generally, even after the rupture has happened with the lower segment scars, the maternal death less occur, and even perinatal death is about 1 in 8, whilst the risk is much higher with the classical scars, 5% of maternal deaths, and perinatal deaths, 6 in 8 women. Remember that a previous history of cesarean delivery does not appreciably alter the course of pregnancy and labor. Remember that the C-sections are associated with increased risk of certain things: increased risk of abortions, preterm labor, normal pregnancy ailments, operative interference, and incidental morbidity. You may have placenta previa, you may have adherent placenta like a placenta accreta, you may have postpartum hemorrhage, peripartum hysterectomy, and even scar rupture. It's much less with the lower uterine scars, about 0.2 to 1.5%, and much more with the classical or hysterotomy scars, which is about 4 to 9%. So the test of a sound scar is actually going to be provided by its ability to withstand these future pregnancies and to withstand labor. So remember that the lower segment scars are the ones that are going to be more sound than the classical scars. So it means if it's a woman that had a C-section many years ago, before they started doing these lower segment cesarean sections, then these women are at risk of uterine rupture, so they shouldn't actually be advised to undergo VBAC. They should be taken straight for a cesarean delivery. So the factors that are going to be affecting the healing of the uterine wound include the imperfect apposition of the cut margins, which we talked about, the presence of any sepsis, the presence of hematoma in the wound, the poor general health of the mother, and even excessive stretching of the lower segment leading to diminished vascularity of the muscles. And when a woman undergoes vaginal birth after cesarean delivery and trial of labor, it's actually successful in about 70 to 76% of the cases. The benefits are going to be including things like decreased maternal morbidity, things like infections and other things related to delivery and pregnancy, reduced length of hospital stay, decreased need of blood transfusions. You may even have this decreased risk of abnormal placentation and the need for successful cesarean delivery in the next pregnancy. The maternal and perinatal mortality rates following VBAC are actually the same, comparable with the elective repeat cesarean section. And if this woman has had a previous cesarean section that was done because of these non-recurrent indications, and the uterine scar is sound, then these are candidates for a VBAC. You can actually channel this woman to undergoing VBAC. But of course, there are other criteria that we're going to be looking at. And for the women that need to be cancelled, as with the current recommendations by the team of obstetricians, anesthetists, and neonatologists, make sure that you counsel this woman and educate her on the benefits and the risks of vaginal birth after cesarean delivery. Now, what are you going to be taking in the history? What are the important things so that you can tease out and you're able to tell that this woman is able to deliver successfully and this one is not? So you want to find out the details of the past pregnancies. When was this pregnancy? When was the cesarean section done? Ideally, this should be more than 2 years ago. And what was the indication for the cesarean delivery? Ideally, Is it a non-recurrent thing where it's a recurrent indication? If it's a recurrent indication, it means that even in this pregnancy, that indication will be present. So they will need a cesarean section even in this delivery. But if it's a non-recurrent thing, then generally you can actually perform, you can actually trial the VBAC. Then of course, has the woman had any past previous successful vaginal deliveries? How long did they stay in the previous pregnancy in the hospital? Because this is hospital length of stay is a good indication of if there were any complications in the cesarean section or not. Any swellings on the wound or hematomas that were noted in the previous delivery, any infections or sepsis in the past pregnancy, any transfusions did they have in the past pregnancy? Is there any history of PV bleeding in the past pregnancy, during labor, or even after the cesarean delivery, where they managed for PPH after the cesarean section or during the delivery? Did they have APH during the pregnancy? What was the birth weight in the past pregnancies generally? And any complications in the past pregnancy? Did they have any twin pregnancy? Did they have any polyhydramnios? Remember, all these things can stretch the scar. Is there any previous history of a low section cesarean section delivery because of a breach? These ones have a very high success rate. About 89% of them are going to be successful when they undergo VBAC. You also want to find out details of the current pregnancy. Was the labor spontaneous? Because these ones have a higher chance of success as compared to those that are induced. Generally, we don't want to induce those patients that are candidates for VBAC because there's a higher risk of rupture. Do they have any pain around the incision site, any acute abdominal pain or PV bleeding? These may be features that are suggestive of impending rupture. What's the latest estimate of the fetal weight on the scan? Generally, if there's a higher fetal weight, there's a lower chance of success. What's the location of the placenta? Is it low-lying? Is there a placenta previa? Is there a fundal anterior or posterior placenta? Remember that placenta previa is going to be weakening the scar, so this is going to be generally an indication of taking these patients to cesarean delivery. Is there any twin pregnancy or polyhydramnios which can stretch the scar? Have you done any ultrasounds to evaluate the uterine scar? Generally, the risk is higher when the full thickness of the lower segment is less than 2.3 millimeters. So we must make sure we clinically evaluate the scar as well as radiologically evaluate the scar before we actually take a decision to let this person undergo a vaginal birth after cesarean delivery. Then are there any comorbidities, any past obstetric or abdominal surgeries? And remember that women that are obese and elderly have a lower success rate when they undergo VBAC. What's our criteria and our candidates for VBAC? So number one, they must have one previous lower segment transverse scar, and it must be an uncomplicated previous cesarean delivery. If it's a complicated cesarean delivery, this requires a consultant's input, generally for you to be able to undergo the VBAC. Then was there a non-recurring indication for the previous cesarean section? Maybe they had a previous cesarean section because of a breech delivery, or maybe a breech presentation, or maybe a fetal distress. The pelvis is adequate for the fetus when you examine this woman, when you do your pelvimetry and your pelvic assessments, and there's continuous labor monitoring that's possible, and you have these available resources. You have anesthesia, you have blood transfusion, you have a theater for these emergency C-sections that can be done within 30 minutes of the decision. The woman should have an informed consent, and they must agree, and they must know all the risks and benefits of the VBAC. Then you must also have a previous diagnosis of CPD, or if it's present, a previous diagnosis of CPD that led to a cesarean or instrumental delivery. Again, this one does require consultant input if present. Then a woman who's had a previous successful vaginal delivery, and even the integrity of the scar has been evaluated clinically and sonographically, and you deem that this scar is sound, then they can undergo vaginal birth of delivery and trial of labor. Some contraindications include a previous classical inverted T-shaped uterine incision, that's a transfundal cesarean delivery, 2 or more previous lower segment C-sections, the pelvis that's contracted or suspected cephalopelvic disproportion, presence of other complications in pregnancy, which may be obstetrics like preeclampsia, malpresentation, placenta previa, or any other medical conditions that may warrant a cesarean delivery, resources that are limited for emergency cesarean delivery, or if the patient refuses the VBAC, any history of a prior uterine rupture, and even any obstetric fistula, which may be current or may have been repaired. Now, how do we manage these patients that have VBAC? Remember that during the course of the pregnancy and during labor, the integrity of the scar needs to be assessed. And it's quite difficult to actually forecast whether the scar is sound or not. And so you need a very high index of suspicion to actually pick out any uterine rupture very quickly. So the factors that you must consider when you're assessing the integrity of the scar include any evidence of any dehiscence during labor, which may point towards impending rupture. We'll talk about this at the end of this lecture. Any scar dehiscence. Remember that this may sometimes be asymptomatic separation or thinning of the scar without involvement of the peritoneal coat. There may sometimes not be any hemorrhage that may be noted. So what do we do antenatally or antepartum management? Generally, patients that have this previous cesarean delivery are at high risk, and we should consider them as high-risk patients for uterine rupture, so they must have these regular antenatal checkups. So at each visit, you must ask about any pain or tenderness over the scar, any presence of any vaginal bleeding, and generally, if this is a woman that's had a previous history of a lower segment operation, they should be admitted at 38 weeks, and they should have a delivery plan that is written for them. Ideally, you must operate on these patients before they get into labor. For those that have had a previous history of a classical cesarean section or hysterotomy, these ones should be admitted at 36 weeks because the risk of rupture is higher, especially during the last few weeks of pregnancy. All cases that are suggestive of a weak lower segment should be admitted at 36 weeks. Then for the intrapartum management, for those that are undergoing VBAC, you generally want to wait for the spontaneous onset of the labor. Remember that induction with these prostaglandins is going to increase the risk of uterine rupture. And when the labor actually starts, you want to assess for any symptoms that are suggestive of a scar rupture, like an acute pain in the abdomen, bleeding from the vagina. You may have tenderness over the scar. Any associated obstetrical complications, you want to send blood for a blood grouping and a cross-match, particularly if the patients are at higher risk of blood transfusion. For example, they have had 2 or more previous cesarean deliveries. They have baseline anemia. You also want to send blood for an FBC because you're interested in the hemoglobin and the platelet level. You want to put up an IV line and start running some Ringer's lactate solution. You want to assess the cervical dilatation and cervical assessments. Ideally, these should be done by the same person, preferably, because they will now be able to pick up and know if this woman is not really progressing. Labor should be monitored, of course, clinically for dehiscence and electronically for fetal behavior. And ideally, we must have continuous electronic fetal monitoring, as if you find any presence of non-reassuring patterns, things like severe variable decelerations, prolonged decelerations, or bradycardia, this may warn us to uterine rupture, and we must act adequately and quickly. Analgesia is not really contraindicated. We may give epidurals. This may not delay the course of labor, and it doesn't delay the diagnosis of a scar rupture. And the delivery ideally must be done by an experienced obstetrician and or an experienced midwife. You should inform the anesthesia and neonatologist in case there's any possible emergency. Also, we may want to augment the labor with oxytocin. This may be done selectively and judiciously. And remember that augmentation does increase the risk of uterine rupture and does increase the risk of cesarean section. It actually increases the risk of rupture by 2 to 3 times, and it increases the risk of cesarean delivery by 1.5 times. So it means you must actually pitch this to the mother and tell them the risks of you giving them this drug. So when you are augmenting or inducing labor, you mustn't use any misoprostol, and you should ripen the cervix with a Foley's catheter. Perform artificial rupture of membranes and oxytocin at 2 milli-international units per minute with a maximum of 10 milli-international units per minute. Prophylactic use of the forceps or the ventouse, the vacuum delivery, to shorten the second stage of labor can be used. And remember, for those that have elective repeat cesarean deliveries, these ones must be done by a senior house officer, or if it's an emergency, they must be done by a registrar or anyone at a higher level. You must send blood for cross-match because a blood transfusion may be needed in these patients. So here's a management algorithm for a patient that has a previous cesarean delivery. You generally want to get an early obstetric scan for pregnancy dating. You want to do your routine focused antenatal care. Give them folic acid, iron, order some investigations like your HB, your RPR, your HIV, your blood typing, your ultrasound for the biophysical profile, your weights, and of course your fetal measurements, your amniotic fluid indices. Then you also want to do your urinalysis and listen to the fetal heart. You want to ask for the pertinent history, so indications of any previous cesarean delivery, the type of uterine incision, any complications in the past pregnancy, and you want to counsel this woman on the risks of a cesarean delivery versus the risks of vaginal birth after cesarean delivery. So if it was a classical incision, you generally want to repeat the cesarean delivery roughly at around 39 weeks of gestation. If it's a lower segment transverse incision, if they had one previous Caesar, it's uncomplicated, then they can attempt VBAC. If it's complicated, then if VBAC is desired, then we should actually get some input from the consultant and then review the notes from the previous cesarean delivery. Then, of course, if it's complicated, we generally repeat the cesarean delivery at 39 weeks. If they've had more than 2 Caesars in the past, we want to repeat the cesarean delivery at 39 weeks of gestation. If they come in and they're in labor, you repeat the cesarean delivery immediately as an emergency procedure. Some complications of unsuccessful VBAC include maternal complications like uterine wound dehiscence, uterine rupture, which is about 0.5 to 1%, increased blood transfusion, increased risk of hysterectomy due to uterine rupture, infections, which have increased mortality, maternal morbidity rather, and mortality, and perinatal complications like hypoxic ischemic encephalopathy, neonatal deaths, and stillbirths. Of course, these are much rare in our setting. Then features that may be suggestive of a scar rupture or a scar dehiscence during labor. Remember that the risk factors of scar rupture are going to be things like 2 or more previous cesarean delivery. If there's a pregnancy that's less than 24 months, remember that your interval must ideally be more than 2 years for you to consider VBAC. If there's induced labor, if there's augmentation of labor with high doses of oxytocin greater than 20 milli-international units, if the woman has had a previous cesarean section delivery and they sutured it up in a single layer as opposed to having a double layer closure. So remember, there is no pathognomic feature that's going to be indicative of uterine dehiscence or rupture, but some things that may suggest include an abnormal cardiotocography tracing, which may show an abnormal fetal heart rate, bradycardia, variable or late decelerations. These are the most consistent finding that you must look for in about 55 to 87% of the cases. Suprapubic pain, if severe and especially persisting in between the contractions, shoulder tip pain or chest pain or sudden shortness of breath, acute onset of scar tenderness, abnormal vaginal bleeding or hematuria, cessation of the uterine contractions which were previously adequate, maternal tachycardia, hypotension, shock, and sometimes even loss of station of the presenting part. All these things are going to be features that are suggestive of uterine scar rupture and may warrant an immediate cesarean delivery. So remember, when you have an early diagnosis of a scar dehiscence or rupture, we want to perform a prompt laparotomy resuscitation, as this is going to reduce the mortality and morbidity to the mother and the infant. I really hope you enjoy this lecture on VBAC. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.